I'm doing good.
Thank you.
We are live.
We are live. Okay, thank you very much. Um, Good afternoon and welcome to the Health Occupations and Long-Term Care Facilities Subcommittee of the Health and Government Operations Standing Committee in the House of Delegates. We are at crossover week, which means we have to be very flexible in our schedules. We also have to be expedient in our decisions. So the bills that we are discussing today, at least one of them has had previous discussion. There's been further follow-up, and we will get, hopefully we're going to be able to come to resolution on all three of these bills because they've all been worked on hard by all of the constituents. So with that, I am going to start with House Bill 776, which is the Maryland Medical Practice Act and Maryland Physicians Assistance Act revisions. This is Delegate Pena-Melnick's bill. Lisa, is that your bill?
It's mine.
Oh, hi, Lindsay.
Hello.
Lindsay, want to tell us what the bill does?
So this bill was actually discussed yesterday. This is making various changes throughout the physicians and physician assistant titles. And we discussed the amendments yesterday, and MHA brought up yesterday that there's a section in the bill that's requiring reporting when there's like substance use issues and it appears in the bill in every section regarding physicians and all of the allied health professions. And there was provision in existing law that said the board may extend the reporting time under this subsection for good cause shown that was being struck, and they asked for that to come back in. I've circulated an updated amendment that does that. The board, MHA, MedChi have all approved that amendment.
Okay. Is there anyone who has a question about that amendment? Seeing no hands go up, then I'm going to ask for a motion. Now, do we have to vote on other amendments as well, Lindsay, or just that
I
one?
don't think we did vote the amendments yesterday. It's the amendments as described yesterday with that additional change.
Okay, so can I have a motion on the entire packet of amendments?
Go move.
Second.
Okay, I've got a motion and a second on the amendments. All those in favor, please say aye.
Aye.
Any opposition to the amendments as presented? Seeing no hands go up, I'm assuming that the amendments pass unanimously. And can I have a motion on the bill as amended?
So move.
Hey, there you are. Seconded.
A motion and a second. Any discussion or questions on the bill as amended? Seeing no hands, all those in favor of the bill as amended, please say aye.
Aye.
Any opposition to the bill as amended? Seeing no hands, the bill passes unanimously. Thank you very much. I'm going to skip 838 for right now, and I'm going to go to House Bill 1478, Public Health, Healthcare, Home Health Care Providers Directory. This is Delegate Hill's bill. Lindsay?
That's me.
It's all
That's
the
me.
folks.
Yep.
Okay. Thank you.
So as introduced, the bill required the Maryland Department of Health to establish and maintain an online directory of each home care provider in the state. The sponsor of the bill has worked on some amendments that rather than requiring the department to maintain the directory, they're requiring them to take a look at it over the interim and to report back to the committees next year on the information about what other states have done, the types of information that would be appropriate to include in the directory, a review of existing home healthcare consumer resources and service programs, and to make recommendations on establishing and maintaining such a directory based on state and federal funding available for home care directories in our state.
Okay. Delegate Hill, you want to speak to the bill and its amendments?
Yes, thank you. So thank you for that, Lisa, and thank you. The stakeholders really got together and worked out the language, and then we, the Department of Health, confirmed about an hour ago that they were fine with those changes. They did want and there's an additional, Lisa, that we're trying to get that information to you now, that they wanted to change the reporting date to December 2020 25. So they just need 3 more months. So by the end of this year, before we come back to session next year. And so that would be the only other thing we would add to the amendment, December 31st, 2025. So if we can include that in the amendments, then I would ask the committee to consider the amended bill and the amendments and vote it out.
And right
And
now,
I think
Same either. I don't know why he likes that.
okay, I need folks to be on mute. Thank you. Is there, I'm looking to see.
so Ms. Kaufman's here. I think I'm trying to see if Lynn or Lauren are here. Ms. Kaufman, can you speak to it perhaps, Madam Chair, if you will?
Yes, Dana, you want to go first?
Yes, we're fine with the language we had asked. Oh, I think I'm, okay. We're fine with the language. We had asked for a couple additions that we all agreed to. So we are good to go. Thank you very much.
And Lorraine?
Hi, Chair. Yes, we're perfectly fine with those amendments. We're happy to work with the Maryland Department of Health and other stakeholders, including consumer groups, to establish a home care directory that will meet the need in the state.
Okay.
So, Madam Chair, I'm going to ask everyone to send the final amendments to my office, and then we can make sure Lisa gets them if that's easier. Do you want them to go directly to Lisa?
Well, I'm going to ask if there's no objection to the amendments, that we go ahead and get a motion on the amendments, including the date change, and move this bill, Delegate.
All right.
Dana, you have other information?
No. I don't know if it was misunderstood. The changes that I have were already incorporated in the amendment that went around.
Okay.
So the date change is the only other issue that I know of, but yeah, we're good to go.
Okay. And I'm not hearing anyone.
And I see the Department of Health is here too, if you want.
Dr. Moran, would you like to speak to this?
I'll just be in the affirmative with Delegate Hill and everybody else. The department's good as proposed with the date change.
Then can I get a motion on the amendments as amended with the date change for the study? I've got a motion. A second? Motion and a second. Those in favor, any more discussion on the amendments? Those in favor of the amendments, please say aye.
Aye.
Any opposition to the amendments? Seeing none. Okay. Can I have a motion on the bill as amended?
So moved.
I got a motion. A motion and a second on the amendments. Any discussion on the bill as amended? Seeing none. Those in favor of the bill as amended, please say aye.
Aye.
Any ayes out there?
Aye.
Good. Any opposition? Seeing none, the bill passes unanimously. I want to thank
you.
all of the stakeholders on those two bills for working together to getting us to these points. I think it's these two bills are ready to go. We'll take them into voting session or consideration for voting. Now I want to go to House Bill 838, Health Occupations, Licensed Direct Entry Midwives, revisions. Before I call on Lindsay, I'm gonna, first of all, thank the Board of Nursing. I asked you yesterday to go back and revisit some of the amendments, and you did that, and I really truly appreciate your feedback and your willingness to engage in this process. I think there's still a couple of things we want to work out, but I'm going to have Lindsay describe the now let me ask this question. Lindsay, do you have the latest version of the amendments?
I don't believe so. I have what I described yesterday, so I'm happy to run through that again, but I don't have any changes to that.
Okay. So, all right, then we won't probably be able, unless folks can agree in concept, we're probably not going to be able to vote on this, but let me go through the things that we talked about yesterday. And I don't have a printed copy of it, so I apologize. It's uh, while I am looking, I do want to remind folks that the Board of Nursing is the board that licenses midwives. And as in that authority, it has the authority to make regulations. We spoke yesterday about how prescriptive the original midwives bill was, because we were being, out of an abundance of caution. But we now have this years of experience, and we have data that shows how the practice works and what the benefits can be to this practice. And so that's why we're seeking to make changes now to the bill. So I think if what I'd like to do is go amendment by amendment. There's just 3 of them, because we did get agreement on one, but the first one. And so, Lindsay, is there anybody who needs a better explanation of and reminder of what the bill does in general? Okay, it really just updates the Midwives Practice Act here in Maryland. So the First Amendment, which we do not have agreement on, is the explicit statement that the midwives are an independent practice. I think that one of the midwives yesterday pointed out other portions of the statutes that designate explicitly independent practice. I don't believe that this amendment makes any changes the intent of the bill at all. So I'm wondering, can I get a motion on the amendment to retain the explicit designation of midwives as independent practice?
So moved.
Second. I've got a motion and a second. Any discussion on that?
Can I just clarify, the statement that they are in independent practice was actually part of the original bill. So the amendment is just to strike that beginning clause, the except for a transfer or a consultation required.
Caitlin, I'm going to look to you. Yes, that's right.
Yes,
Clarify.
and our intent is the clear clarification on independence that Chair Collison described. We had some concern about, except for transfer or consultation, creating a situation where we don't want a physician that we're consulting with to feel like they're taking on the midwife as a dependent practitioner, because that will actually make it very difficult for us to get practitioners to consult with us. They do not want to take on the liability of the patient too. So we just thought that modifier that came in through drafting was confusing that a little bit. The intent here is just to clarify in law, and frankly, going through this process has made us even more wanting to have that clarified in law, because there is so much kind of confusion about how we operate.
So Lindsay, can you restate what the amendment that retains that that statement would say now?
Sure. So the original bill, if you're looking at page 6 of the bill, lines 13 through 16, said except for a transfer required under this subtitle or consultation required under this subtitle, the practice of direct entry midwifery is independent and does not require oversight by another healthcare practitioner. So the amendment is just to strike that modifying clause before the practice of direct entry midwifery is independent. And that statement was part of the original bill. It's not meant to current law, but it was part of the original bill. So the amendment is just to strike the except language and start the sentence with the word the practice of direct entry midwifery.
Okay, thank you. Rhonda Scott, please. Unmute.
Thank you, Madam
There we
Chair.
go.
Appreciate it. So I just wanted to clarify the board's suggested amendment in that the language that that is in the COMAR currently is in COMAR, not law, not statute. And the board is willing to mirror the language in COMAR that is under the nurse midwifery regulations that was cited yesterday. So it's more regulations than statute, and the board is more than willing to mirror that specifically for the practice of direct entry midwifery in their COMAR as well. So rather than having it in statute, the board is willing to do as it is with the nurse midwives in the direct entry midwifery COMAR regulations.
Okay. I'm going to look to Caitlin for a response for that.
I mean, I think obviously it's the committee's decision. We prefer it in statute just because we experience so much confusion integrating into the healthcare system, whether it be receiving practitioners at hospitals, our confusion between us and other types of midwives, interaction. We're always trying to get other maternal health practitioners, whether it be obstetricians, nurse midwives, to work with us on some of our other requirements in the Practice Act, and want to have something we can clearly point to that you can consult with us, but you're not taking us on as a subsequent practitioner and things like that. There's just, a lot of barriers in this space, and we think this is helpful, but, we'll leave it to the committee.
And thank you, Caitlin. And I have heard from a number of midwives about the need to keep it explicit in the statute. So we have a motion and a second on this amendment. I'd like to vote. Those in favor of this amendment, please raise your hand, and so that I can see.
Aye.
Okay. There, now we got it. Okay. Let's see. I have to look down. I've got
Anemia next.
okay. I've got Delegate White Holland, Delegate Riley, Delegate Bagnell, Delegate Morgan, Delegate Woods, Delegate Warman, myself. Okay, Delegate Bandari. All right. Any opposition to that First Amendment? Delegate Hutchinson, are you voting for or against the amendment? Oh, you're on mute, or you are muted. You're okay. So that amendment passes unanimously. Then now let's move to the second amendment, which is related to the transferring the patient with severe anemia that is unresponsive to treatment. The board continues to have concerns because they indicate that they would not consider this a low-risk pregnancy. I am going to go to Caitlin because I think there's some more information on this amendment.
Well, I mean, again, so we would press to have some flexibility around total transfer just because you dip below that hemoglobin level. What we're proposing with the language in the redraft as it currently stands would be if a patient, through the series of testing that we are performing regularly throughout the pregnancy, both at the start of pregnancy, at the 26-week mark, those are pretty standard labs. If someone is showing as anemic, they would have the opportunity to get treatment and basically get their levels up above that level. If we're finding that they are not responding to that treatment, we would agree that there's a higher risk level and that they should transfer. And that's, what we're suggesting, just having some flexibility to give them the opportunity to get that treatment, whether it be from us through iron supplements or from a physician if they need something more intensive like a transfusion. And I don't know if Christine's on. I apologize. I can't see everyone on the screen with ACOG. I think we had added the modifier to try and be helpful, that to like this 36-week mark, because that's generally when we start to get a little bit concerned, you're getting close enough to delivery that if you're really not responding, that's when we would want to be transferring, unless there's something else going on. I think and Christine, I don't want to speak for you, but that was maybe creating some confusion because, if you're testing all along and you're still not responding, they don't want to preclude a transfer earlier in the process if that's what kind of the tests are showing. So I think they wanted it to just go back to the plain unresponsive to treatment. We're fine either way. So I'd leave that to the other stakeholders in the committee. But and Christine, again, you could speak to the ACOG amendment.
Yes, Christine, if you would give us the opinion of the obstetricians and gynecologists.
Yes, thank you. Caitlin's correct. After she explained it to me a bit more, we were fine with severe anemia defined as hemoglobin less than 10. That is unresponsive to treatment. That was before I saw the Board of Nursing suggested amendment. They really would prefer it to be on transfer, but if it's going to stay on consult, the original language would work.
And Caitlin, does it stay on consult?
I'm sorry, I'm struggling to go. I mean, so my understanding is the Board of Nursing's position is to keep, we cannot, as soon as you show up as anemic, we have to transfer. And I mean, maybe I'm misunderstanding the board's position, but they want no changes to current law about anemia. Our position would be that before we have to transfer a patient completely out of their maternal health provider and their home birth setting that they have chosen, that they have, we have the opportunity to either get them an anemia treatment or coordinate them with another health practitioner to provide that treatment. If they are still not responding and showing as anemic, then we agree under this that they would transfer.
Okay, I'm going to go to Dr. Jordan.
Good afternoon. So I'm Dr. Jordan. I'm the advanced practice member on the board and also the secretary, and I sit on the legislative committee. So our concern is that per the regulations, the practice of direct entry midwifery is that for the care of a low risk pregnancy. And in the setting of severe anemia, that would not be a low risk pregnancy. So the concern is, this statute is in direct conflict with the current regulations. And we're also concerned, again, about the risk to the mother and child with severe anemia. There's really no definition around what's an appropriate response, the time frame that we're thinking of for that appropriate response to treatment, and who really determines what the appropriate response is or makes that delineation. So that's why we're maintaining our position on this amendment.
Okay. I'm going to take Nikki Williams, and then we're going to see if we can accomplish something on this. Nikki Williams.
Yes, I'm a direct entry midwife. And I just wanted to elucidate, what happens when we transfer care, especially in Maryland, where we have not a lot of OB access. We're losing clinicians because of COVID, whatever. When I transfer care, it takes 1 or 2 months to get that person in to see a doctor. By the time that person has seen the doctor, we have treated the anemia. It only takes 2 or 3 weeks to retest and see whether the hemoglobin has gone up. I also want to make another point that anemia is not severe until it's below 8. So we're actually talking about moderate anemia here. If our hemoglobin target is above 10. So what you're in reality doing is, if I have to transfer care, which means I cannot touch or deal with this person again, the person is going completely without care between us transferring and them being able to see a doctor. I don't know if that helps you envision what actually it means for us to have to transfer care in real actual practice. Thank you.
And I think just maybe one thing to add, and maybe a little bit in response to Dr. Jordan, is I think what the bill is contemplating is you've received treatment and now you're above 10. That's responsive to treatment. You're no longer in the anemic range. If you're still below 10, transfer. It just gives that flexibility around getting treatment without having to completely give up your birth situation from a patient perspective.
Does that help, Dr. Jordan?
That definitely provides some clarity. We can take that back to the legislative committee to see what their thoughts are.
Okay, so what I'm going to ask I'm going to go to Delegate Bagnall.
Thank you, Madam Chair. And I listening to this dialogue, it makes sense where the, where the sticking point is. And I just might want to, based on Ms. McDonough's comments, say that maybe it is which has been unresponsive to treatment, because I think that is unresponsive to treatment sounds like we're starting to treat it now. And there doesn't seem to be clarity that it continues to remain below 10 in response to treatment. Does that make sense?
Caitlin?
I don't know what the language would be, but I think.
Yes. I believe me, Delegate, I've been struggling with this and like, when it happens and things like that. And this is modeled after other provisions you can kind of see in the bill, like similar to like what happens with hypothyroidism. If you have hypothyroidism and you get it treated, you can stay in care. You aren't risked out. If you don't have it treated or it's still, occurring beyond that medication, then we agree you've risked out of care.
So it's like finding the language that clarifies that which remains unresponsive to.
Okay. So you're still under again, like we would say you've received treatment, you're still under 10. But right now, the second you show up anemic, you're out, basically.
Right. So I'm going to go to Lindsay for a second. And Lindsay, given, I can't see you on my screen, given what Delegate Bagnall just was suggesting, can you recommend some language that implies that the person has been receiving treatment and is unresponsive, and their level is still below 10?
Yeah, I'm looking at it. I might play around with it a little bit, but I was thinking about trying to move the clause so that it would say defined as hemoglobin measured after treatment as less than 10. I'm not a practitioner, but I think that would help to clarify that measurement is taken after you've been treated already.
Again, basically, because we
and I can draft this, put it all together and send it out to make sure everybody's okay with it.
Okay.
That's what my current thought is.
Dr. Jordan, any thoughts on that?
Sure. We can certainly take that back to the legislative committee. I did have one question because this came up in our discussion because there was the whole note of 36 weeks and hearing that we could be looking at 2 to 4 weeks to determine whether or not they've responded. So my question is, if we have a pregnant mother who is identified as having a hemoglobin less than 10 and they are so close to giving birth, right? We identify it as anemia at 36 weeks and we're looking at 2 to 4 weeks for a response. What is the risk to that patient? What's the risk to that mother and baby while we're waiting for a response?
So I think our proposal was that's why we kind of tried to have that 36-week modifier was at that point where delivery and birth may be more imminent. If you're showing up as anemic, we're proposing that would be more of an automatic transfer for exactly the reason you articulated, Dr. Jordan.
Okay.
So if people are okay with that, like that was our mitigated suggestion.
Yeah, if we could see, an amendment to that, we can certainly take it back to the legislative committee. I know that was a big area of concern for us that we're identifying at 36 weeks. What's the likelihood that treatment is going to be appropriate or it's going to respond before that person gives birth?
May I object again?
Yes, please.
I think in that case, something like severe anemia, defined as hemoglobin less than 10, and then a colon with a Roman 1 measured after treatment, or Roman 2 based on blood tests performed when the patient is 36 weeks pregnant. So in that case, there wouldn't have to be any treatment first. It would just be if it's measured after at less than 10 after 36 weeks or 36 weeks or later, then it's immediate transfer. Or if after treatment it's measured at 10, it's transfer.
And that's why we love our council. Thank you. So you'll work on that, and we will bring that back tomorrow. I'm hoping we can wrap up the other two pieces though, which I think, so in terms of transferring a patient with significant fetal anomaly, the board's recommending as determined by the board in regulations. And the same for upon the issue around the medical records, the board's recommending as determined by the board in regulations. And just to be clear, I started off by saying the board has the authority to do these things in regulations. So that's, I think, a really good way for us to proceed. I just want to make sure that the regulations are consistent with the current practice and experience of the midwives, so that we are and the patient outcomes, so that we're not putting unnecessary constraints based on things that haven't happened, or that or the worst case scenarios. So am I saying that correctly, Caitlin?
Yeah, and again, I mean, it's almost like the reverse of the independent practice situation. We believe the board, as the regulator and licensing body, always has the ability to kind of within the scope of the statute to set those regulations. And frankly, we love to see more of this done in regulations, where I think you can get into some of the flexibility and nuance than as it is. I mean, part of the reason we struggle with this is because it's in statute and it's so rigid. I think we would just note, like with accompanying the patient, transferring the records, and then, this kind of wide range with the congenital anomalies, is a lot of this ends up being determined, we think, on a patient by patient basis. Like in this circumstance, you should absolutely transfer and things like that. So, keeping that in mind, I mean, I think the board already has the authority to do the regulations. So, I mean, I can't really object to that.
Okay. And in the last one was the question about reporting, and the board's recommending that we amend it to say that they will update the regulations to conform with this with the subsection A of this section. So I believe that we can agree to those three things being handled in regulations. Rhonda?
Thank you, Madam Chair. So yeah, I just wanted to assure the group that whenever the board does engage in promulgating regs, that we involve stakeholders as the experts in that process. So thank you.
Thank you for that clarity. I appreciate that.
Yeah.
Kaylin, is your hand still up, or?
So yeah, I apologize because I've got like 3 documents open. So is the proposal around the reporting requirements so we had struck, I think, section A and then kind of directed the board in consultation to develop a new reporting requirement. So I don't, and assuming that the board would do that through regulation, if it has to be the same as A, like, I just don't know, like, are we tying the future regulations to a provision that would no longer exist in the law? And maybe I'm misreading it, and maybe that's a Lindsay question.
No, Caitlin, you're right. I mean, so subsection A was struck, and it says right now with the amendments that the licensed direct entry midwives will be subject to reporting requirements developed by the board in consultation with the committee and any other stakeholders deemed appropriate by the board. So that is basically by regulations. You can clarify adopted by the board in regulation. But that is subsection A now with the amendments that you've got.
I mean, I think we're assuming the board would kind of use the current process, what we're doing in vital records, like again, not as a separate process, but as a basis, things like that. What other nurse midwives do as a basis. But I mean, our goal is just to get back together with the board and develop a new reporting requirement. And if they can do that through regs, I think that's fine. That may just be, I just don't know if we can reference an area law that will no longer be in law.
Lindsay, I'm hearing you confirm that.
Yes, that's right.
Right, but that this would
If
actually.
the board knows what was there and they can use that as a starting point.
Yeah.
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 Okay.
Conceptually, I think we're in the same place as far as,
Mitzi?
Yes, thank you, Madam Chair. Hi, everyone. I'm Mitzi Fishman with the Board of Nursing. So I believe our reference here with subsection A, we were agreeable to that first amendment, Caitlin, which would be reporting requirements developed by the board in consultation with the committee and other stakeholders deemed appropriate by the board. So that would be the new A.
Oh, so that's the new A. Got it. That makes sense, actually.
Yep.
Thank you, Mitzi. Sorry, I wasn't thinking of a new A.
No problem.
Okay. So I'm going to ask the committee, the subcommittee, if I can get a favorable motion on the amendments related to the fetal anomalies and the transfer of records and the reporting requirements, which are all essentially going to be turned over to the Board of Nursing to go through their regulatory process. We don't have the language yet. We'll come back with the exact language tomorrow, but if I can get agreement on those concepts, then the only point that we will not have resolved 100% is the anemia part, and I think we're very close on that. So can I get a motion conceptually on those three pieces?
Move the conceptual amendments as explained by the chair.
I'm sorry, can you clarify? So with the significant fetal congenital anomaly, that's with the language that directly impacts the birthing process or requires immediate emergency care.
Yes.
And then with regard to the transfer of records.
Right, that's the one that's.
I have correct.
Right, and after the word newborn, as determined by the board and regulations. Got it, Lindsay? I know it's confusing.
Yes, thank you.
I have a motion. Do I have a second?
Second.
On this.
Second.
Okay, I've got a second. Anyone need to discuss those amendments any further? Seeing none. Those in favor of these conceptual amendments, please say aye.
Aye.
Any objection, any opposition to those amendments? Okay. Lindsay, you can't object. Sorry.
I just wanted to ask one more question. So I had an amendment in here that was being discussed about accompanying the patient to the hospital. Is there a resolution on that piece?
I think we're okay with the determination being made by the receiving practitioner and the LPM. And I don't want to speak for Rhonda, but I think the board was okay with that. Yes. Yesterday? Was this yesterday?
It could have been 2 hours ago. And it feels like yesterday. Rhonda, were you okay with that?
I recall, I believe so. Mitzi, please.
Yeah, I didn't see that in today's
I
notes.
can't remember.
Yes, as far as the accompaniment requirement, we were okay with the amendments there.
Okay.
Yep.
All right. So tomorrow we'll come back with the completed amendments, and hopefully we'll all be on the same page, and we'll be able to move this. Again, I cannot express enough my gratitude for the subcommittee and your contribution to this process, but also stakeholders from all of the different perspectives that we have here. You know, we have the Maryland Hospital Association, we have the American College of Oncologists and Gynecologists, we have the Board of Nursing, we have the Board of Health, and we have the representatives of midwives. So those are a lot of people to come together and on a very important issue and complex issue. So I just want to extend my warmest gratitude for all the work on this, and I really appreciate it. And I look forward to us meeting briefly tomorrow on this bill. With that, unless the subcommittee has an issue, then we will adjourned for now. Thank you all very much. Have a good afternoon.